First order is to call to order. Second is the approval of the minutes from March 31st, 2025. Do I have a motion?
Second.
Second. All right. We have a motion. All in favor, say aye.
Aye.
Aye. Motion passes 3-0. Next is public comments. If we have any public comments, we have 2.5 minutes. If you can come to the podium. Seeing that we have none. Going once, going twice. All right. Next on the agenda is the overview of the current town healthcare plan. And Mr. DeMora, you've taken that?
Yes, sir, and thank you very much. I'm happy to introduce it. Good afternoon to you, members of the committee. It's good to be with you. It's budget time, and healthcare is a big part of our budget, so it seemed appropriate that we take some time to discuss the health of our healthcare plan. And with us today is Rick Gant. Rick has been with us from the beginning. He's a big part of the success we've had with our plan. And he and his team at Gallagher have put together a presentation for us. And at this point, Mr. Chairman, if you're comfortable with it, I'd like Rick to go ahead.
Yes, we would appreciate that. You got the memo to wear purple today. They got the memo. They got the memo. I happen to be the chair, and I did not get the memo. I appreciate it.
I'm going to stand up. I'm always in a car, so I hope you don't mind. Yeah, good. Well, thank you. My name is Rick Gant. I actually started out in the restaurant business in Charleston here years ago. Joined family business and employee benefits 30 years ago. Now get the pleasure of sitting at the helm of Gallagher, which is the third largest privately held brokerage firm in the world. And I run South Carolina, but I also get the pleasure of being lead strategist and data analytics lead for the town of Mount Pleasant. Been working with Eric and his team for quite some time. So that's kind of my history. Certainly we've got a pretty big team under us, but I am the one that gets to talk to you today. Really, Eric asked us to talk about where we've been. What did we do? Why did we do it? Kind of the trends, where we're going, and then just really just answer any questions you guys have. But to paint the picture, we got to go back, and we're going to go back probably to 2009, 2010, and we'll look at numbers, and there'll be some graphs and trends and things. But at the end of the day, we just wanted to do a better job with healthcare, and so it is a constant battle. It's not anything that you can say you've got it lit and then walk away from. As a matter of fact, Eric and his team have been exceptional at this. Building strategy way back when, it's something that they constantly pay attention to as well. But I love this slide. It's an older slide, but I wanted to start here because it really talks about what we did and why we do it, and what we did and why we do it, but it's just a very simple case study, and we used this slide back in 2013 when the town of Mount Pleasant actually won an award called a High Performing Health Plan Award for the results. But the important thing on this slide, if you look in the middle, you'll see two numbers, and then you'll see where our goals started with these two numbers. But it says 89% of the participation in direct primary care plan, which is high. As a matter of fact, you'll see this as high as 80, 90, 98% in today's world, which is just wonderful, meaning at the town. And then more importantly, 83% of the population improving the line clinically or holding the line clinically, just not getting any worse if they have a condition. And so these were a couple of the goals that we set out to be, is 80 and 70. And right here at this picture, it was 89 and 83. And underneath it, it unpacks it a little bit more. If I was a diabetic, what was I spending? If I was participating, what was the average? And it really painted the picture of why we did what we did. Now, things have changed dramatically since that time, but the premise still stays the same, that we're trying to give to get, is what I like to call it. We actually give benefits to individuals, and what we find in return is they're just better. They're better people. They're healthier. They feel better. They're moving. They're better spouses. They're better moms and dads, better in the community, and better at their job too. So this picture had a 5-year look on our cost, and it was our cost year over year was less than 1%. We'll fast forward to this through the 15 years, and it won't be much different. There's always some highs and lows, but this is why we did what we did. And we had high cost. We had employees that had high chronic risk. I remember there was a lot of loss of work time with work days away from the job, from sickness. And so that was some of the reasons we did what we did. So the challenge was we just weren't winning. We weren't winning the healthcare game. And we had a lot of individuals with a lot of risk. As a matter of fact, 69% of our population had something, right? Not unusual that we don't have, that we don't have anything. So there's a lot of people that certainly have something. I know I do. And we get things as we get a little older, but 69% was certainly high, and we needed to do something about it. We also knew that if we didn't do anything about it, healthcare trend would continue, and we would be at a cost of close to $20,000 per employee by 2020. Now, we didn't get there. We're not even there. So we're able to kind of stop that bleeding, but that was the trend. 9 and 10. And then we were just out. We were sick too often. So this is where I talk about the strategy. And again, Eric and his team, we read books. We went on the road. We looked at what everybody was doing. We toured clinics. And we even partnered with some other individuals that were doing great things in South Carolina and the Southeast. And so we decided to meet every 2 weeks. We have slacked off on that now. But in the beginning, we met every 2 weeks, and we looked at everything from changing the plan design to changing the payroll deductions to doing what most employers do with healthcare, making the employees pay more. We just didn't want to take that route, right? So we decided how can we move on this and work on well-being, and that was the push. And here were the two goals, or three. Number one, get 80% of our population participating, working with a primary care physician and following standards of care. And y'all just saw the number. The picture was anywhere from 89 to as high as 98%. So we got that goal, and I'll give you an update on that soon. And then 70% of the people at risk holding the line clinically. It's not getting any worse. And that came from Dee Eddington's work at the University of Michigan. And we practice this. This is kind of what we do each and every day. And then try to give a better delivery of healthcare. Healthcare is broken. How can we get a better delivery to our participants? So, post-strategy stats. A couple of stats I think are neat.
Excuse me 1 second, sorry.
Yeah.
At that time, that was 2010-ish. At that time, what percentage of the healthcare costs were the employees paying? Do you know?
It was 12 or 13% at that time. And today it's 11.
Okay, thank you.
Mm-hmm. And there's a slide in on that. So we have benchmarking information. You'll see how we stack up from benefits and payroll deductions, and you'll see that strategy. I do, sir. So post-strategy stats, just taking a picture. Just in the last 24 months, and again, a lot has changed, right? We've been through COVID. We've had a turnover. We've had people come. We've had people go. But just in the last 24 months, our risk has decreased by 20%. So we have a data analytics package that puts everybody in the risk score. And the individuals that have a risk, 20%, moved out of that risk, and they moved into normal, which is great. Remember, that's holding the line clinically or improving. We did have 6% that got worse. So we keep an eye on that. We're always looking at it and seeing where are we going to go, what are we going to do about it. So we have seen clinical improvement in the last 24 months, but we've seen it constant ever since we started this. Now, it doesn't mean we're perfect, right? I mean, we still face plenty of headwinds. Pharmacy is something, as a matter of fact, we were talking about it yesterday, and we're trying to take trigger and actions to reduce pharmacy, but pharmacy costs have gone up. Here are two good examples: GLP-1s, which everyone talks about in the market now. I mean, we spent close to $300,000 in the last 12 months on that, 263 scripts, and inflammatory medicine has been close to 800,000. So we still have plenty of challenges, and they're going to be episodic challenges. But if we can hold the line again clinically on the chronic risks, good things happen. And if you look at our 15-year average, excuse me, our cost is now 1.45% compared to the market year over year of 6 and 7. So we were able to freeze that, and that's one of the reasons why we still pay the same percentage.
With the 90% population doing the primary care standards, is that the annual checkup? Is that what that?
Well, there's two metrics. Number one, you have to say, I'm going to take that plan. It's called a direct primary care plan here at the town. 98% of the population do. There's only 12 people that don't. So that's trigger one. But also to be engaged there, you have to have a physical, go to that doctor and be, following standards of care. So if you're young, standards of care is physical possibly. If you've got, if you're a little older, you've got to do 3 or 4 more things, right? So that's what that metric means. And it's moved around. In the last 3 years, as a matter of fact, it's gotten better, which we'll show you. So that's a good win. So now what we did is we just graph it. So in this graph, it's kind of busy. What we did is the top graph is where we were headed. That is the trend if our projections were right and we were plus 6 and 7% year over year. The very bottom is our actual cost without our fees for direct primary care because we pay for it. It's a fee, it's a cost, no question. The blue that looks very similar to it above is our fees that include direct primary care, which we should include. The purple is a linear of the 1.45, and then the public entity is the light blue, and that's the cost per employee. So we actually run a survey. We run the largest survey in the country, so we're able to survey public entity too, and you'll see this in a benchmark study. So if we back that up a little bit, I just took a couple of things out, and on this slide, it's just the actual cost with and without DPC versus our trend. And then the last one is our actual cost with DPC versus our trend. So a little picture. So looking back to our goals where we were, 80%, this number has consistently been about 90 or over. We have 98% enrolled, and you'll see clinically we have 85% that are going more than just once or twice. They're actually involved, so it's a great thing. And our spouses have increased going to this model by 20%, which you'll see as well. 70% of the individuals at risk were consistently over 80. So that means our people that have a chronic risk, heart, whatever, hypertension, we're holding it in line, at least for the most of us. And then, how are we doing from the people, the employees' engagement results? The recent engagement survey said that it was the number one benefit. Benefits ranked very high, but the on-site clinic also was one of their number one benefits. So we know that it's delivering a better health plan, especially if you adopt it. So a little bit about our population. So now we're going to go into our data analytics program, and I just threw up 3 slides on data analytics. Again, there isn't anything we can't see. This thing does predictive analytics too. It tells us where we're going. It tells us what our issues are, and it really unpacks everything. But as you can see, our population, I think in the middle left is where I like to spend most of my time. 49%, excuse me, allergies. 49% of the employees driving 61% of our claims. Spouses are driving about 21%, and dependents are driving 10%. If you look to the right of that, you'll see what each employee cost us per member per month, spouses and dependents. And then we add it all up at the bottom. So we have 1,428 belly buttons under our plan currently. The other thing that's pretty important is the top right. It's risk. So it looks at our relative risk score, and it looks our gaps in care. So gaps in care, am I doing what I'm supposed to do for my condition? Relative risk score is how do I stack up with the industry? And there's 36 million people in this data analytics. And where am I going? And you really want these around 1 or under. So still a little work to do, but it's not horrible. Yes, sir.
You go back to that a second. I know this is probably very easy for you to read. It's going to take me a minute. Tell me about the CGI. What is?
It's called a care gap index. So
Okay.
it means if I'm a diabetic, am I doing what I'm supposed to do to practice standards of care? Am I having my A1C checked? Did I have my foot exam, my eye exam? Am I seeing a doctor on a preventative basis?
And the RRS again. Apologies.
Relative risk score. So it takes your care gap, your claims, what you're taking for meds, what your clinical conditions are, and it gives you a risk score if you're doing what you're supposed to do and where you're headed in the future.
So 1.2 over 1.0. That means that that compares the risk compared to what the employee's doing towards it, or are those numbers in relation to each other? If that makes sense. Is a 1.2 over a 1.0 a bad or a good thing?
It's fine. Right around 1.0, I'm happy with. As you'll see, if I've got a condition and I'm not taking care of myself, I can see these get as high as 10, 20, or 30. So you want it around 1.
Who's doing a better job, the employee or the spouse? If that makes sense on that, the employee.
The employee.
Okay, that's what I thought. All right.
But look, the spouses
still
cost
more,
us
yeah.
more money too.
What's that?
As you can see, spouses are 20% of our makeup, and they're running 28% of our claims. As we spend more money on the spouse than we do on employees. Now that's traditional, especially in public entity. That's why it's so important that we get them in the model as well, which has increased by 20 points in the last 3 years, but it's important.
But we're not allowed to email the spouse or involve the spouse or anything like that. Is that correct? I mean,
The town stays away from that,
right.
We do have,
100%.
as they should, right?
Right.
So none of the HR team know
Right.
any risk of anyone. There's no protected health information, but our
The
direct
spouse
primary,
still has to do their annual.
Yeah, still has to do the annual. Correct.
it's an incentive.
Anybody over 18 has to. That's on it. Is that correct? Any adult, even if they're on the plan,
It's covered adults and
have to do the
covered
annual.
spouse, adults, and employees.
Have to do.
We are not asking the children to do it. They can though, because our clinic can see them.
Thank you.
You're welcome. So this next slide talks about our risk and the percentage of people. And so it basically is saying our top 5%, which is 72 humans, are really costing 61% of our total costs, and the average is 62. So or 63. That doesn't really bother me too terribly much there. But it does paint a picture. 72 drive most of the claims. And then the system breaks us down. We're either A, B, or C. Right. If we're A, that means there's 62 of us that are spending quite a bit of money. And this could be pharmaceutical or medical. But see that average risk score there on our people that are A? You'll see that they're 8.0 and the care gap index is 2.3. So that's why it's so important that we get in and try to help them get better. And that's what the whole goal is. Group B's.
Are these numbers based on 2024, or is this like a composite of multiple years?
It's a 2-year look back. It's
So
23
2023
versus 24. but
Calendar year 2023.
that is correct.
Okay.
This is our actual data. B's are individuals with a risk, and that could be musculoskeletal, that could be hypertension, it could be hyperlipidemia. If I'm a B1, that means I have a condition and I am not doing what I'm supposed to do about it. If I'm a B2, I am closing those care gaps. And then C's are everybody else. And as you can see, what a C costs versus what an A costs is pretty substantial. So we pay attention to it. Now, we don't share these details, right? But we have to know what's going on to build the strategy to be the best we can be. So it's just a snapshot of the analytics. And what it's also telling us is, I reviewed this just this week, our A's are holding steady, and we'll probably spend a little bit more money on them in the years to come. But our B's, their cost is going down, which is good. A's usually are episodic. So think inflammatory disease, cancer, things like that, injuries. So now this goes into our benchmarking. So on the left, you'll see we have two plans, right? So 10 years ago or 15 years ago, we said, all right, we'd love for you to pick our direct primary care plan, go to the doctor for it. And if you do so, your benefits are better. You pay less for health care. If you choose not to do it, you go into the market. That's fine too. It's all about choice, but you would pay more. So we have 12 people on the standard plan, and everyone else is on the direct primary care plan. So really kind of concentrate on that far left slide. And then we've compared it with national, all employers. And you'll find this interesting, especially when you get into payroll deductions. And then we compared it to the same size employers. And then we compared it to public entity, which is extremely important. And then we compared it to the Southeast. So our plan in general really stacks up well. And there's a lot on this page. Our deductibles are in line, even though we had changed that recently. And it was one of the changes in the past 15 years is we changed the deductibles and we changed payroll deductions once or twice, but it hasn't been much. I'm sorry, Jake, do you have a question? You're talking about the 6,000?
Yeah, three. I think it's more. That's okay. It might be a medium of the past 2 years.
Got it. Well, I'm happy to talk to you about that, but our plan is it's $1,000 deductible times 2 max family, and then same thing out of pocket. So you should never pay any given year more than $6,000 as a family.
Mr. Tinky, do you have something?
On your comparisons, it's all about how you compare it. So when you're doing the Southeast or public entity, obviously we can compete against all comparable size businesses. So is that what the Southeast is, and how do you determine that we're sort of apples and apples in the Southeast against all employers, not only municipal employers? I mean, is it a certain number of employees, or is it a certain payroll amount, or how do you know that you're comparing apples to apples? Because sometimes you can have some really high, some low, and how do you come up with that?
Well, it's an average of all,
Okay.
right? And so the Southeast is all of the Southeast that answered the survey.
So all businesses of all sizes.
Public entity, private, public, it doesn't matter. Public entity was just public entity. And then there's your number break from 500 to 999. This is the number of employees. And then the last cut was national throughout the country.
I do have a question as well. Any reason, and maybe it's just personal, any reason somebody would sign up for the standard plan? Because that doesn't have you, is there better coverage for certain circumstances or something? Because, I mean, on our direct primary, that is, so standard is not going to our doctor's office, correct?
Correct.
Any reason anybody?
They don't like the doctors in the clinic, or they have been with their doctor for years and they just don't want to change.
Okay.
Again, there's 12 employees on that plan.
All right. Thank you.
So benefits are comparable, especially with generic meds. And there's some other things that don't show up on this benchmark, which we'll get into, which the on-site clinic offers, free meds, free labs. If you need it, you can get it. But if you go to the bottom of the page, that's really what will shock you a little bit. So our single rate stacks up with public entity, as you can see, at $82 a month versus the $84. But our family is a good bit nicer at $282 a month versus the $383. But look at national in the middle. So most people pay about $150 a month for single coverage and $600 for family. So as you can see, we've got not only great benefits, but our payroll deductions are good too. And 15 years ago, it was, we don't want to just make people pay more money. How can we do this different? And so that's why we did what we did. So I am going to just unpack the direct primary care plan a little bit more because most of us are on it. But if you look to the left, you'll see primary care at 0. Risk management supplies at 0. So if I go in and I need help, they are going to help me. They will give me the meds I need. I don't even have to go to the pharmacy if I don't want to or don't need to. Labs, they can pull all my labs. They do certainly do all the preventative care. They can take care of myself. They can take care of my spouse. They can take care of my children. That's what I love about primary care physicians, and they do a great job of it. So this is something that just doesn't get stacked up in the benchmark. This is something that you don't see in the state health plan, for example. And by the way, our trends for the past 15 years have been 1.45%. State health plan has had a tough last 4 years have been tough. And their trend's been 8.42% in the last 4 years, but the last 10 it's been 5. Right? So you're doing a better job of managing the risk. So I think that's important to point out. I'm going to jump forward a little bit to the payroll deductions. And what we find is we don't really make changes. We'll sit around and talk about what's everybody else doing in the market. We've talked about high deductible health plans with HSAs. We've talked about individual plans. We've talked about the state plan. There isn't anything that we haven't covered. We talked about 16 years ago, instead of offering the benefits we did, put a high deductible health plan with this, which is really where we were going. But it was unpopular and we just didn't do it. So the concentration was all around, hey, let's get everybody healthier and happier. And so that was the whole goal. So that's good. So back to the payroll deductions. John, you had asked a couple of these questions. In 2010, the town paid 90% of healthcare costs, and employees paid 10%. In 2023, the town paid 88% and the employees paid 12%. Updated right now, the town's paying 89% and the employees are paying 11%. So it's held consistent. And one of the ways you're able to do it again is if your increase is 1% or 1.4 versus 6, 7, 8, 9, 10 every year, you can absorb a little more. So that's been good. Here's some more on the benchmarks, and we just looked at this, but the average cost for benefits now in the nation's $150 for single, $600 for family. That's 200% higher for single and 300% higher for family. With public entity, we're about level on single, but family, we're still to the good by 70 points. And most public entities employees pay 14%, 28% of family cost. So we're doing pretty good there. Some of the other stuff I wanted to talk about, pharmacy is huge. And that is probably where we've concentrated most of our efforts in the last 12 months. We're doing everything in our power to make sure we're paying the least amount for the drug. If there's rebate associated with the drug, it comes back to the town, and those rebates have gone up. Are y'all familiar with that? Name brand, okay. And you can purchase or get medicine at the on-site clinic. Every time someone fills a script at the on-site clinic, it costs us about $10. If I go to a CVS and stripe my card, it costs the town $22 plus the copay from the employee. So it's cheaper to do it on site. So that's really great as well.
Are you saying that the formulary, that's where they compound it on site versus, or is that different?
We have a formulary pharmacy
Right.
at the on-site clinics, not compounded, but it comes in prepackaged bottles for a 30-day supply. Here's some of the meds, the top meds that they're delivering. And if you go in and you have a common illness, we we've got on site what you need, and you walk out, with no charge, and you get the med, which I love, right? Because it drives me to the clinic. If I have blood pressure issues, maybe the doc or the MA can check my blood pressure and help me with that, and just build that trust. But that's exactly what that means.
The question I asked then, following up on that, is on some of the compounding pharmacies, they're radically less expensive on some basic drugs. They don't cover them all, but the ones that they do compound are maybe a tenth the cost. And so, do you find that some of the local compounding pharmacies are participating in the program as well?
Yes. So if you go on site, certainly it's zero, but anywhere you go off site, we have tiers for any meds, whether it's a compound or a regular generic or wherever.
Okay.
We're incentivized to go to certain places. The compounds are huge. A great example of compounds, people were compounding GLP-1s because they couldn't keep up with them. Well, the FDA just said you can't do that anymore because they caught up. But compounds absolutely come in play. But our center doesn't do any compounds.
Okay.
Because there are no pharmacists there.
So just to recap, any of these filled at our doctors are at zero cost to the participant. And I mean, is this something I don't know that I've had anything. So, but this is something they advertise there, and they don't even write a script for any of this stuff.
They just go get it.
Okay.
But they can write scripts. Or let's say, your cardiologist or ologist says you need XYZ. You can take it to your primary care physician, and if it's on site, you can get it.
No, you can take your script there.
Sure. Well, they don't accept scripts. There's no pharmacy. But let's say I'm taking hypertension medicine,
Mm-hmm.
and I was going to CVS or somewhere else to get it. Well, we have hypertension on site, and it's pretty inexpensive anyway. Why not go on site and get it checked and get it free of charge?
And do we educate our team on that?
Every day, all the time. That doesn't mean everybody listens and gets it. So it's every day, all the time.
I've been here 3 years, so I obviously wasn't listening.
Well, I mean, you think about that
I
benefit.
don't have any prescriptions, so.
Well, that's good.
Yeah.
But you think about that benefit. I mean, it's one-stop shop. It really can help us in, primary care physicians can cure 90% of what else.
They're not on this list. Thank you.
I can name a few.
Well, the things that aren't on this list, we have a mail order that is associated with the clinic. We'll send it to your home. The goal is to buy it the cheapest way possible so the town spends less money. But we can hand these drugs to you or someone else and still save $10 and give it to you just because we're moving around the system. So I think some things that are important here. So we asked the on-site clinic provider to give us some data too. And the thing that's really important, I think, is the bottom right-hand side. And we have been through three or four different versions of a clinic. I mean, at the old municipal complex, we actually had a clinic in it. Does anybody remember that? I know you do, sir. But we moved. It didn't work because people didn't trust it. So we moved it out. It moved next to Publix, and now it's where it is today. And we're building a new center in North Charleston. So we've been through different vendors. This one, especially in the last 3 years, I mean, there have been challenges. No one's perfect. But if you look, our employee engagement, that means I am engaged with a primary care physician. They're doing what I asked them to do, and they're working on improvement. That has gone from 72% to 85%. So again, I don't want to confuse everybody, but there's two goals that play the game, right? I'm in the DPC plan if I choose that DPC. If I don't, I'm in the standard plan. But am I actually working with that doctor? That's what this means. And so that's up to 85%, which is great. But more importantly, look underneath. Our spouses are up 20 points. They're costing more money. So that's a good lead indicator for me. Next slide just goes over the services. And just in 2024, we had close to 12,000 services done in the clinic. And there was a 15% increase in 23 and 31% increase in 22. So we have more people engaged, and we're doing more in the clinic, which is good news.
Do we have telemed? I don't know. Do we offer telemed, or we call in the doctor?
We do, but it costs money.
That's an additional plan, or it costs money.
Well, you have, so you can call the on-site clinic has telemed services within it. It does. So you can call in the doctor emergencies and all
Mhm.
types of things, and that's all included as well. We also have telemed through our health plan, but it costs $59 every time. You have a copay if you're on it. You pay a copay, but you have that too. We don't get much utilization in that. And that's typical. It's what most insurance companies and carriers have is telemedicine, but you have it through your on-site clinic where most of it's driven. Did I answer your question?
Yes. So you're saying instead of calling Doctors Care and doing telemed, we can just call our own doctor
It's a great thing, right? Build a relationship.
during hours, right?
Correct. Even after hours, they'll call you back. There's always someone on call. But having that relationship with that doctor is huge. Hey, I've got a rash. Take a picture of it. Let me see it. Come in. Don't go to the ER. That kind of thing. Every time our employees go to the ER, it costs us $3,186.
How much?
$3,186 every time they go. So we'd rather them go here.
Emergency, right?
Right.
Yes, sir.
It's not like doctor's care on the weekends.
No, it's less.
But you're even stating we don't need to go to Doctor's Care. You're saying call the primary care on the weekend, and they will call back at some point. I mean, I guess what I'm saying, if I have a question or he has a question, then probably 30% of the employees have the same question, or yeah,
I didn't know you could do that on the weekends.
Yeah.
right.
Oh, it's
Neither
like
did
you
I.
go to doctor's care if you want like a flu test on a Saturday or whatever.
Well, you can still call in. But in open enrollment meetings, when we're talking to the employees, we say, I mean, here's your first line of offense, and second, you go to the on-site, get your meds on site, get your labs on site. If you can't, there is urgent care, but you got to pay more money. If you do feel that there's an emerging issue and you've got to go to the emergency room, go. We're not going to say please don't go, but it just certainly costs more money and it's open all the time. But they do connect even in emergency services with your on-site. But again, this is something that we go back to and educate and try our best. Doesn't mean it's perfect. So those are some health center stats. I do like the Net Promoter Score is 87. The most recent one is 87 points, and that's a pretty good Net Promoter Score when average in the industry that we're in is 30 and 40% at best. We spend a lot of money with the clinic, though. I mean, especially with the North Charleston Clinic, this has popped up a little bit. So we're spending quite a bit of money with it, but it's still saving money. But it's also helping us just reduce the risk and hold those costs in line.
The North Charleston one is built out or is not built out yet?
It's being built out. I don't know if it's fully staffed. Christy, you have? It's red. Yeah.
Same format as over here, because sorry about that. What
You
happened
would
last time was we didn't have full control. We have full control now, so we can replace if necessary. Don't have to look for. Okay, thank you.
Sure. And what we're moving into, which is pretty exciting, we were on the phone about this morning, is musculoskeletal is an emerging risk, right? It's always ever changing. So back, neck, knee has become a big issue at the town. I think from a commercial standpoint, but certainly on our employee benefits. And so we're actually testing a PT on site for 10 hours. So we've got the room with the on-site clinic, so there'll be a PT in there. We pay for an hourly fee, so we save money. And if Rick needs mobility issues, he can be prescribed that by Dr. Snow or someone. And so we're pretty excited about that. And that's coming right now, starting soon. The other stuff in here, y'all, talks about
I have a question on that.
Yes,
sorry.
sir.
Would that be post surgery as well? PT?
Sure. It can be post-surgery. It can be you just have mobility problems, back neck knee issues, and just like the Army does, let's teach you what your issue is and try to stretch you out of it and PT out of it.
Thank you.
So we have close to 200 individuals that have back neck knee issues right now in town of Mount Pleasant. We think there's a correlation. We know there's a correlation between safety and health in this.
And when would that PT be active?
I think it's 5-1. Okay, I got that one right.
At both locations? Or-
Yes. Well, just Mount Pleasant. Christy, come join me.
I got your back.
Yeah, thank you. Yeah, we're just building that out.
Trying it out. Okay.
Yeah.
Thank you.
So the rest of this, y'all, goes into our funding, who we use to pay our claims, who's our network. I don't know how deep you want to go into that. So I just wanted to kind of open it up. Eric, if you're all right with that, just a question.
I am. I had a couple points that, if you're okay, Mr. Chair, just a couple points I wanted to add. But first is, it goes without saying, but I feel necessary to say it anyway. We on the town side do not see specific individual healthcare information, but we get information aggregately. You know, how many people have a chronic disease? We don't know who exactly has that chronic disease. Wanted to mention that. The success of the plan requires participation. And so we've been successful at managing the cost over these years, but future success is directly dependent on our employees and covered lives taking the plan seriously and participating in it. If people stop participating, we'd be back in front of you on what to do next, because costs would just start to grow out of control. Additional point, we manage chronic diseases well. That was the main focus of this when we started, but it's the episodic events that create the fluctuations. You know, if it's not the chronic diseases per se, it's unfortunately someone having cancer or something like that, which is just part of the human condition, right? And lastly, and with Rick's help, when we took this on, I guess 15 years ago now, well, I never thought I'd learn so much about healthcare. Never intended to, and it still goes on, and we still meet a lot more than I would have thought of when we originally just to manage it. For next year, we do not expect, we don't anticipate, we're not planning on any increases in the plan as far as premiums paid or any other costs. We are looking at offering options for savings to the employee, which will result in savings for the town as well, but on some prescription drugs, perhaps even dental, allowing additional options that the employee can decide to opt into for less expensive service. And so, yeah, so I wanted to say that.
Yeah, Mr. Tinky.
I mentioned it last time, but I want to congratulate the town. Learning about it now and seeing what you're doing with the wellness program, it obviously works if you're more proactive instead of reactive. Also want to, I'm pleased that you've got Gallagher. I worked with that industry and the golf industry for many years, and I guess it's one of the reasons why one of your brokers is now mid-amateur champion in golf, Mike McCoy. But no, you've got really good people out there that are networking with everybody and doing a really good job. And so the question I have is, as you look at the best of the best, the top 5%, what do you think are the 3 or 4, 5 things that all companies are doing, but the top 5% to be preventative, to get people engaged, and what makes the biggest impact for their health as well as the bottom line for the company?
Thank you for the question. And we have a lot of old pro golfers that work at Gallagher, Charles Warren and Kyle Thompson, but not me. My uncle told me to stay in the office and work. We'll get that clear. I'll go out and boat with you. So we study this certainly each and every day. I think the first thing is you have to, from a contract perspective, have everything in line.
Have everything what?
Everything in line, every policy reviewed. So from the TPA to the network, do we have the best network if I'm not going to the clinic? And you do with Blue Cross. Do we have the best third-party administrator that is the most flexible and efficient in paying the claims? And what are those terms in those contracts? And then on the pharmacy, it is huge. You know, we have to audit it each and every year because it's so fast moving. So these are just core blocking and tackling that has to be done on the backside. The employees don't see most of this, but it has to be done. So it has to start there. I want you to spend the least amount of money on a drug. I want you to spend the least amount of money on a condition if you get it. Driving those individuals to those places is the second thing. So how can I go? We're horrible consumers of healthcare, right? So I think we will research buying a air conditioner more than we do heart surgery. We just follow suit sometimes or something critical. And so getting to the places with the highest quality is where we want to go. In the past, we used to use here at the town a plan called Medical Advocate Program, and it would say, hey, Rick, you're having this condition, you're having this procedure. Do you mind traveling? Do you have a doctor? And they would help us make good decisions. We scratched that because the participation got to be where it was too low, and we now use that through the direct primary care. But Dr. Snow and the doctors know who's doing the best work in town, and so we steer that. So I would say steerage to quality is number two. But the thing that we see that is absolute best in class is hitting those two numbers, 80-70. Having our people have a relationship with a primary care physician and practicing standards of care at 80% or higher. And it sounds easy, but it's not. I mean, it's been easy at the town because you built the plan to do it. It basically incentivized me to do it, right? But then more importantly, the 70% at risk, holding the line clinically, and that's where it's hard. So those are huge, and that's the hardest thing for an employer to do. A lot of employers now do outcomes-based wellness programs. Michelin, for example, they go on metabolic syndrome, and they throw $3,000 at the employee or take $3,000 away if you're not doing what you're supposed to do in those 5 metrics. Well, we don't do that. We didn't want to do that. We still want you to have the activity, but we're the give to get. So the 80-70 rule certainly is that. And then just being transparent with everything, which goes back to the contracts. So those are the top, I would just say the top 3.
Well, it looks like one of them that you're doing is having a clinic, well, not a clinic, but a gym and wellness nearby, and a culture of let's be mobile and let's be active and let's watch our health, because if we're fitter, we feel better. If we feel better, we have lower cost and we have better family relationships, etc. So I think the more that you're doing that, I think the better. So any of the programs that you see that we're not doing in the future, let us know, so we can have those proactive programs. I mean, I've seen programs where people exercise together in the morning for 15 minutes or whatever, but whatever the programs are, it's at least good to know what they are.
Well, the town, and thank you for that too, but the town has done exceptional with that as well. I mean, that's one of the reasons in 2013 that award came out. I mean, I remember working out with the police chief at that point, pulling over tires when I was in town. You guys not only do the heart and soul work of chronic conditions, but you also do the wellness work. There's well-being and then there's wellness. You've got a great gym. You get people out. You get points if you do this or that. So that's what most employers do. And they don't go in deep to the chronic risk, which is what you're doing. But we certainly talk about that. I mean, we talk about the trends all the time.
Well, thank you for your answer.
Yes, sir. Thank you for the questions.
I was just saying, I'm pleased because I thought the whole time you were buttering us up for saying that we need to drastically increase fees or deductibles or something. So I was ready to argue with you, but we don't have to, so that's good.
We had those discussions, Jake, 16 years ago. And remember that, Eric? I mean, it was, we said, hey, we're going to bring your deductibles up. We're going to do what everybody else does. Or those were some hard questions and answers.
Yeah, well, and I do think there are areas where pay probably does lag behind private industry, but this is an area that far exceeds anything I've seen. And maybe, I mean, I've never been with a Fortune 500 company, but at least with small businesses, they don't offer anything like this. So anyway, so I heard no rate increase, no increase in deductible, and no increase in max out of pocket.
Yeah.
Beautiful.
There's your open enrollment meeting.
That's. I'm done.
Yeah, that's all he wanted.
There's some small tweaks.
Definitely a consumer.
Now, are y'all involved then with the incentive fit and the health savings plan and all that as well?
Well, we don't have a health savings. We have a flexible
Yeah, what do we
spending.
have? We have the
Flexible
spending.
spending.
Sorry.
Certainly, we consult in any and everything that you guys do. We don't necessarily get involved on a day-to-day on the incentive. We're getting ready to change that, as a matter of fact. But yeah, if it touches your people from an employee benefit perspective, we're involved in it with physical and emotional health, no question.
And well, I guess the incentive fit does help, or I mean, I guess that just encourages.
It certainly does, but it by itself, which is what most
Right.
employers have done, doesn't get you to the 80-70. It just doesn't get there. So it may get 12, 13, 14%. It gets us out. It gives us another avenue to continue our health and health goals. Using the track, working out, using the gym, giving us points, to be able to improve my A1C or my hypertension or whatever. So we use it in tandem, but it by itself just doesn't move the needle.
I've got two more things. One, I know healthcare. With a small business, I just got actually had a meeting yesterday. They want to go up 15%. But now we got to go argue back. It's like, just give me the number. What I got to come back and argue? I mean, it's a negotiation, but it is a 15% increase as of right now from what I'm hearing. And I'm seeing that year over year. So the fact that you're not going up is awesome. And I forgot the second one. Hold on a minute.
Take your time.
That's okay.
I'm worried about the 15 points.
Yeah, 15, that's a lot, right?
Yeah.
It's a big, I think I just surprised myself again, and reality is setting in on that. But how do you keep, with the doctors being contracted with us, how do you keep them incentivized? Because they're kind of guaranteed, right? I mean, they do an excellent job over there. They're awesome people. How do we keep them incentivized to want to do a good job every day? And they do an incredible job, by the way.
Yeah, it's a great question. I really don't like to speak for that vendor
Right.
that does it. That's Proactive MD, but I do know that model, and I know what they're incentivizing the doctors to do. So in traditional models, if you don't have direct primary care, a doctor may have a patient panel load of 4,000, right? In these models, we have two doctors. We have 1,428 humans, and 85 to 80% of them are actively using them, right? So the patient panel is less. They love it, number one, because it's a different lifestyle for them.
Mm-hmm.
They get to spend time with me on my condition, get to know me. That's why I want that relationship with them. And from a lifestyle perspective, they love it. So to influence them into direct primary care versus where they are in the regular physician world, they love that. Number one. Number two, they make about the same amount of money from base salary, but they are incentivized in various ways. So like we have KPIs with the provider that they have to hit certain metrics, clinical quality, and that gets passed on to the physicians too. So we want over 70% or 75% utilization in standard of care for diabetics, for example, and we're at the 83, 84%. Well, if they hit that metric individually with that patient population, then they get bonused off of that too. I think there's some other things that they get. I can't speak for them, but I know those are the three major things.
Okay, thank you. Does that end your presentation?
Yes, sir. And
Okay.
if
Any other questions? Great
What do you-
job. Thank you.
You guys like it? Y'all are on the health plan?
Yeah.
You're not on the health plan, John. You
No,
got
I'm on
your.
that. Oh, I'm not on. No, I'm on this one.
Okay.
Yeah, I'm not on my own. I'm not on my own health plan. No, I'm on this
Smart
health
man.
plan. Yeah, 100%. I mean, it's a great health plan. It beats mine.
Yeah. Well, I hope, if anything, you guys learned a good bit more about what we did and why we did it, but utilize these great benefits. And when you're talking to people as the leaders of HR and benefits, tell them to use these great benefits, because each and every time we get scripts filled there or labs filled there, or Rick goes there and he didn't know he had a condition and we take care of it, we save life, hopefully, and we save some money.
Well, and
Well,
I know it's
thanks.
not top of mind, and I know it's a tough discussion, but right, the employees going home and being able to speak to their spouses about it, because we cannot, right? And understanding that graph and that a little bit of education, like even the fact that I didn't know we can call the doctor's office on the weekend. I've got, you can ding me for 3 doctor's care telebeds, by the way, that was me, on the weekend, actually. I didn't know that. So calling in doctor's care and doing that face-to-face on the computer, I did not call our own doctor's office. I didn't know that was an option. So
We used to have hours on Saturday.
it was later. I think it was later. Yeah, I've gone on a Saturday, actually. I think it's till 1 o'clock on Saturday, 12. Yeah. So,
Yeah.
but I think you're doing an excellent job, and I think they're doing a great job, especially that we're not here to talk about an increase. We could have ended this conversation 5 minutes in. Yeah.
Well, hats off to everybody. I mean, HR, Christiane, and Eric and the team, they work hard to do it, and that's why it works.
Yeah, good work.
Thank you for good work.
Thank you very much.
Thank you.
Good
Thank you,
job.
Eric.
Okay, moving on to agenda item 5, discussion and recommendation of human resource information systems.
Good afternoon.
Hello.
So we sent out the RFI, the request for information. All the responses were due back March 31st. And the purpose of that was really to see if there were companies that are capable of providing all the services that the town requires. Right now, the HRIS includes HR functions, benefits, payroll, and timekeeping. So we were looking for that same package and all the services within that. So we wanted to see who was capable of doing that, what the costs were, and what the timeline was. 7 companies ended up responding. They all indicated that they could do the work either through their own program or through a third party. As you can see, there were drastic differences when you look at costs and the time frame for implementation. So this information, the purpose of it and what we hope to do with it is to use it to determine if a change is necessary and what that would look like, what the costs and the workload would be. But this was really just to get information from the field, not to select a company.
I guess my question with this is, there's probably a few columns missing, and that would be, are we comparing apples to apples or apples to oranges? I know for a fact that Dayforce doesn't handle the amount of HR functionality that some of these other systems do. So I would be interested in seeing those other columns that would probably be in here. I understand why this is being presented, but when you compare apples to apples, how many Dayforce is already implemented at 0 cost and $288 a year, but how many other systems have to be utilized compared to any of these one-stop shops that could cover the entire spectrum? That's where I'm kind of, a checkbox that says these are these are the 20 things we do in HR, and these are the amount of systems that we use to do that. And is what I'm kind of imagining. I would be interested in seeing something a little closer to that.
So this is a brief summary.
Right.
The
Yeah, I understand.
RFI had, I would call it our wish list.
Right.
So it has all the functionality. We listed all the functionality that we currently have and need, as well as functions that we know are out there and would be very beneficial for us to have.
Right. So if there's 25 needs, and one of these is only covering 5 of those needs, but one covers 20 of those needs at near the same cost, and I'm just stating, then really the cost is lower for that other. So that would be, so you have something like that
Yes,
that shares
so
that. And
we
can-
have the detailed submittals that each
Okay.
of them provided, and we could also do a much bigger spreadsheet.
Excellent. Okay. Thank you. Any questions on this for right now?
No, anything that you learned from the process that was helpful to you and going through it as far as things that would be helpful for your operations?
I think it was good to see that there are many options that can do them. When you dig in, I think you have to see how well they do them and at what cost. It was interesting to see the wide range of costs and the timeline. So I think that's something that would require more information.
And how many years of operation have we had with Dayforce?
It was implemented in 2017.
Okay, so fairly recently. And if you had to calculate your startup cost, not counting the one-time costs that are here, your startup cost of employee engagement and working through, what would you say would have been the cost associated in 2017 to make that change to Dayforce? Was it what type of cost would that have been?
That predates me, so I can't truly speak to that. I can find out, but I can't speak
Well,
to that.
anytime you have a transition like that, there's a fair amount of cost and change, and it's addition to the normal workload that people have. So that has to be weighed into it as well, I would think.
Yes, I do know that there were months of implementation training, especially the people that use it the most, which
Right.
is HR and finance. There was a lot with that. And then those are the biggest users, but it really does affect all the employees. So there's some level of training provided to all of them.
So there'd have to be some type of silver lining at the end of or a bright spot at the end of the tunnel to know that if you're going through these things or in addition to your normal job, that positive things would happen on the other end. I guess that's where I'm going
Yes.
with it to understand it. Okay.
Yes, you do have to look at the whole picture, how it serves HR, but also how it serves finance, the IT team that would have to support that, and the end users too.
And to John's question, I guess, were there any things that would be solved that would be more easily solved by other systems? And so that's what you look at. You look at the cost benefit of both.
Exactly.
Okay.
Yes.
Thank you.
Thank you.
Okay. Thank you for that.
And Mr. Chairman, we have in our draft agenda for the second budget committee meeting of council a consideration of some funding for this software in next year's budget. That is currently on a draft agenda. I don't know if this is something that yourself or members of the committee wish to deliberate over that again, whether we're ready for that or not ready for it. Appreciate some guidance on whether that's something you'd like to see on that agenda or not.
I feel like I have no issues with Dayforce, and Dayforce works well. Seems like it's working well. I mean, they're sure on a wish list. I think there's probably a couple of functions you could name that could be on there, but for the price that we're paying, plus the price and time it would take to switch to another company, I have no desire in pursuing it further. Personally, but I'm just one.
Well, I'm a new guy on the block, so I don't have a full understanding of it, but we are living in an uncertain world, especially right now. And so I would be likely to stay with what we have for now, unless something compelling came up from our HR department and the finance and says, boy, we're missing the boat here. We need to do some things. So I'd be less likely to do it. I think we have more compelling things for our agenda for our overall operations right now, but I'm always open to doing things better and more efficiently if it shows itself.
I would state that I'd be happy to have HR at the next committee meeting because I do think I think we're just missing that huge component, which is that Excel sheet. I mean, I don't think anything can be answered that if we can't, we, like Jake has stated, we think Dayforce is doing a good job, but if it's doing 5 of 25 things and something else on here does 20 of 25 or all 25 at the same, because there are some that are about the same cost, if it brings in that time and not time to, not time that we lose staff on it, time that our staff can spend more time with their team members instead of doing drag and drops on Excel sheets and emailing each other and all of those type things. I happen to use a more efficient HRIS myself, although a small company, and it takes from interviewing, it takes care of the entire life cycle of the employee to include payroll, scheduling, and things of that sort. I just don't think Dayforce does that. So I don't think it's fair to answer this question right now without seeing that big Excel sheet that shows here's everything we need and here's everything that each one of these we will do. So we don't have the return on investment for each one of these because it's not showing what they do. So I would be interested in seeing that before making a decision. So I'd be happy to put that on the HR committee this upcoming committee day. Okay. So if we could have that, I would think that would best serve this committee as a whole.
Yes, sir.
Okay. Thank you. Yeah. Good with that? Okay. All right. Thank you. All right. Item number 6 on the agenda is executive session for personnel matters, the discussion of town administrator contract, discussion of corporation council contract. Post-executive session, committee may take action on any item, including any subsection of any section listed on an executive session agenda or discussed in an executive session during a properly noticed meeting. Do we have a motion to go?
So moved.
Second.
All right. All in favor?
Aye.
Aye. All right. We are in executive session. is to adjourn.